Dr. Yap has completed his, just a short one, completed his undergrad medical study in Jinan University, and then he has shown special interest in wound. So he completed his master degree in wound healing and tissue repair from Cardiff University, and inside the wound he is interested in facial injury, and he did a lot of clinical study on the facial injury. So he also has been awarded a fellowship in the European Association of Pharaoh in Wound Healing in 2023. So now he's a wound head for Sabah. He also the wound committee member for the National Wound Committee, and he also the adjunct senior lecturer in Monash University. With that, stage yours.
Thank you very much for a kind introduction. So, my topics today is how to manage a difficult stoma. I think it's also one of my topics given for those people who are attending my post-basic stoma in ILKKM in Badan this time. So, however, because I'm giving a 10 minutes here, so I think I need to revise a bit, which is not similar as what I'm giving during the ILKKM post-basic stoma courses. Next. So, managing a difficult stoma, I'm just telling you that what are we going to approach, not so much about the difficult type of stoma, what you're going to have. For example, like stoma stenosis, and then your ischemic of the stomas, and then you have your stoma gapping, okay, or the macerations, or the excoriation secondary to whatever causes of it, high output, low output, that kind of a typical stoma itself. And then whether the stoma was actually being created at the full crease of the skin or something like that. So that one, let's say you guys really wanted to know about that part, you can actually sign up for your post-basic stoma, and we can talk about it in ILKKM, because that will be not 10 minutes presentation. So, before that, so stoma management itself, you have to go through a lot of multiple approach itself, because it can arise from the stoma itself, or the surrounding skin, or the appliance being used. Meaning to say, I think just now the sister has been telling you the way that it's supposed to use to apply the stoma bag. If it's not being applied appropriately, or the stoma bag that you choose is not appropriate, then you always get the problem. However, there is actually one thing that I didn't write down here, black and white, because today the moderator is surgeon. So there's one factor, is the surgeon factors. Okay, I always say this. Wound management, why the wound is not going to heal, whatever risk factors that you listed out, there is always one factor didn't double it black and white out. If black and white is legal and documented, that is always a healthcare professional factors. Yang menyebabkan luka tidak sembuh. Okay? But what is it? Like I say, some other times we have the time to talk about it. Next slide. Thank you. So of course, when we assess the stoma size, I think just now you already mentioned the shape and the size and the type of stoma and the protrusion level, whether is it being functioning appropriately, and then your stoma, the mucosa region, is it really pouching out or not pouching out? That is actually one part of it. Because later on you choose the stoma bag, how are you going to put out the stoma, the mucosa into the bag itself? That is actually affecting whether the patients will have any problems or not. Next. Then, Then about the skin care, yes, we have to look into the skin care, because this also can cause a lot of issue. Let's say some patients will have an eczema or any dermatitis or dermatological issue as well. And plus, if let's say you put on a stoma bag, I'm not sure have you encountered some of the patients, the moment you put on a stoma bag, they always tell that I have to change it daily. Okay, when you change it daily, they always tear off the skin. And then some of the people, they have a very hairy skin on the back, on the abdominal skin part. When you tear off, the hair follicles will be teared. The moment your hair follicle is teared, and do not forget that this is a stoma, so all the whatever gut flora, microorganisms will all come out, you'll be having a folliculitis. You need to say all your hair follicles may be infected as well. So what are you going to do with that? Because they keep on tearing. So this is the types. Today you heard about hydrocolloid dressings. Do you know how many types of hydrocolloid that we know? Nobody company tells you. Yeah, there is actually a lot of things that under the hydrochlorides, whether it's a thick hydrochloride or thin hydrochloride, and the type of hydrochlorides that they are using, porcine-based, Hawaiian-based, or plant-based, blah, blah, blah. Okay? Including plant-based such as the seaweed and things like that, because you also have gelatinous and things like that. So all these things, the material, is also affecting on the skin itself. So that's why when we look into it, stoma skin is actually part of it, that the skincare is actually part of the difficult stoma management as well, because it can irritating because of the appliances, okay? And also it can cause a fungal infections and redness and folliculitis as well. Next. And also the, like I said, appliances selection. So you have to see the types of the stoma problem that you can have. If let's say the stoma was actually shrinking or the stoma was actually retracted. Why is it retracted? Is it because of the skin fold region here? Now, this is why I say this is a surgeon factor. Because the stoma is created, now this is where the belt is. So if you cover the belt, what will happen to the stomach? The stoma will actually retract it. So if let's say the stoma retracted, you ask the surgeon, can you do a refractioning the other muscle? So, or the patient is not favorable because of critical illness and then a lot of inflammatory powers inside there. So they have difficulty to run the kind of a surgery to refractioning the stomach. That is, so you can think of like what are the problems, what are the solutions that the patients can have. So maybe you can think of like convex. Okay? To protrude, so you push the skin so the stoma can come out. That's what we call a convex type of stoma bag. You may want to use a flexible rigid or a stoma belt, especially when there is a herniation. Okay, herniations of the stoma under the skin, but at the peristoma region, you may need to compress it. But you cannot compress the stoma because they're still coming out the feces. So you may need the belt to compress the other side, let the stoma come out. So the bowel can go in. Again, when you do this kind of belt, you make sure that you assess it properly so that the stoma, whatever the herniation can be the bowel or the small bowel, doesn't strangulate it under there. Otherwise, Mr. Lau will chop your head because he has to reset the bowel. Once it's strangulated, the hernia being strangulated there, the bowel needs to be removed. That is a massive surgery. Okay, next. Addressing the specific complication. Gotta see what, like I said, retracted stoma, you may want to use it. And then prolapsed stoma, you may want to use the large part. Why? Because the mucosa is coming up outside, where there's a long time of it. Then you can see whether is it get complications or not. Why? Mucosa is always moist. And do not forget that the anatomy of the small bowel of villi, they can easily get dehydrated. Okay, as long as they're exposed. So there is the reasons why when you put on a stoma bag, they always have a wrapper. You know wrapper? On the plastic bag, there's a wrapper there. So that's why you can see that where do you think the wrapper is from? Because of perspirations of all your vessels and then all the villi, everything on the mucosa region. So either they would like to retract it back, they need to find out what is the pathologist underlying that causes of the stoma protrusion. Whether maybe there is a growth, okay, there's a tumor growth underneath the causes of that protrusion, they need to find out. So if let's say you can't, because it's normal, everything is normal, but just protrusion is coming out, so you may need to get a big patch of the stoma bag. So it depends on the types of the stoma complication that you have, and the other one is a high output, especially the proximal part of the bowel. Let's say your duodenum, or not duodenum, jejunum, or the jejunum ileum region, because of trauma, because of prolapse, because of the perforations due to secondary to traumas, whatever trauma, road accident trauma, or patient has a fall or whatsoever. Okay, so all these things with the stoma, high stoma output, then what kind of a bag that you would like to use for the patient, and how are you going to secure, other than secure, how are you going to manage the peristoma wound? The skin, especially the peristoma wound skin, because high output stoma usually, the stoma output is very liquid, and that liquid contains a lot of this gastrointestinal enzyme. And the gastrointestinal enzyme is even more corrosive than your bleaching agent. Okay, you think bleaching agent is good to dye your clothes, everything, right? And you can actually use your hand to touch the bridging agent. This one, the moment you touch it out, is really, really corrosive. So there's the reasons why when you have such thing, gut, the liquid or whatever, the gastrointestinal fluid, leak inside the abdomen. So you can imagine how painful the patient is. And they can't tell you where exactly the pain because it can flow everywhere. So that's why the patient always can easily get peritonitis. So that is a nightmare for a surgeon. Because you need to investigate and you open up inflammation of the bowel adhesion. It is not a good surgical field. Alright? So that is the reasons why managing such a thing, helping your surgeon, helping the patient is very, very important to these kind of patients. Okay, next slide. The other one is the leakage prevention. I think just now, the last few slides I insisted just now, it was mentioned, when you cut it appropriately. Doesn't matter whether you are giving a ileostomy or colostomy or ileoconduit. Ileostomy, exactly you have to cut, but from my experience and from my advice to you, even though a colostomy, they say that you can longer skip that conversation, however, you better cut exactly. Even though why? People say that, oh, don't worry about colostomy, because colostomy is a well-formed feces that come out, not so much about liquid like ileostomy, okay, or like ileoconduit where the urine output is there. But I can tell you that sometimes when the patient dies here, even though it's a colostomy, it's still liquid. So in that sense, it's longer, then the whole skin will get excoriated. Excoriated is not an issue. When the patient develops sepsis, that is the worst part of it. Why? How are you going to refashion the stoma when the patient develops sepsis? And there is an excoriation and the peristoma skin. Not to say the surgeon cannot do a surgery, he can, but if I move it, will I get better? Or the other part, we get also excoriation. If this one excoriation, then where you want to put the stoma anymore? So the surgeon will think twice whether I want to refashion it. If they don't want to refashion it, then what about the excoriated skin? Now patient is sepsis. Are you able to do something about it other than antibiotics? Are you able to manage the wound? It's simply quite like a wound management, but are you able to manage the wound? Are you going to put silver, whatever antimicrobial dressing at the peristoma on the skin? So that's why I say you better cut it exactly, follow the stoma area. Don't make it loose, even though it's just a colostomy. Okay? Next. Of course, these are the stoma paste, the stoma ring, which just help you to secure so that when the feces can come out, it doesn't touch on the skin itself. And of course, the stool consistency, that one you may need your surgeons or you need your gastroenterologist or you need a physician, whoever manages the patient and look at it. Whether they're giving laxative for the patient, they forgot to off it, or like lactose and or maybe they soften up the stool. These are the things that are actually not very good for the stoma, especially that, because it will be more liquid to come out. Alright? And then hydration purposes, like I said, keep the patient hydrated, encourage hydration, and especially in the ileostomy and also the prolapse of the stoma. Next. And of course, patient education. Because diet, patient when they go outside, they will diet, the food sometimes can cause it more stoma, high output as well. And then the nature of the food content can be smelly and causes a lot of odors and things like that. So these are the patient educations, what are they, how are they? I think you can go out to the websites or maybe whatever the assistant tells you later on. Then you have to tell them, and the patient education is more important. But second thing, I think this one ostomy support group, if you can have, that will be good. Why? If I can see this person also having this kind of problem, hey, macam sama, ni kawan ni, or brother, you know, like that, then they will ask you, how are you going to manage it? Then maybe rather than I learn from you. Because you are just a healthcare people. Healthcare people can talk anything. So I'm a patient, I put that down. But if I met a person who also having such a problem, and they can manage it successfully, hey, ini kawan dah walaupun dia bukan apa siapa. Because it's not a doctor, it's not a nurse. That's why this kind of education and the support, the confidence that we get from the patient, the compliance with you win the whole battle. Next. So consultation with stoma, I think is my last time. We refer patients to an experienced stoma nurse and for personalized fitting, troubleshooting and ongoing education, if there's any things that you have. So hopefully that in the hospital is that you may be having 1 or 2 endostomal nurses, or maybe inside the ward you at least have 1 endostomal nurses, that will be easy for you to manage the situation. Next. To summarize everything is that you got to understand the types of the colon or the types of the bowel that you're managing, and also the problem that the patient is facing, at the same time the type of food that the patient is having. Because all these things will actually help you to design by knowing the type of stoma that you're having. Like I said, the material you know, that is your weapon. But if you do not know your patient, you don't know the battle. Okay? But you don't know the weapon, meaning to say you don't know the type of stoma that you have. You know the patient, you also cannot win the battle. So it will be good that you know both sides, what the patient is having. Everybody are individual, despite they have a stoma, despite they have colostomy, despite they have the same ileostomy. But the type of the food that they eat, the output can be different. So this is the reasons why individualize it. Know your weapon means your material, the stoma material, stoma paste, stoma adhesive, stoma powder, whatever. How are you going to fully utilize the on your patient? You win most of the battle. Next. Thank you.